Welcome to our comprehensive guide on the pharmacotherapy of schizophrenia. By the end of this video, you'll be able to recognize the key signs and symptoms of schizophrenia, understand its underlying pathophysiology, and identify the main treatment goals for patients. We'll also cover how to recommend appropriate antipsychotic medications based on patient-specific data, compare the side effect profiles of different antipsychotics, and describe the essential components of a monitoring plan to assess both the effectiveness and safety of these medications. Let's embark on this journey to deepen your understanding and clinical skills. Schizophrenia is a complex, chronic disorder characterized by disorganized and bizarre thoughts, delusions, hallucinations, inappropriate affect, and impaired psychosocial functioning. Individuals with schizophrenia often experience significant disturbances in their interpersonal relationships and their ability to function in society. This disorder affects both thought and emotion, making daily life and social integration challenging for those diagnosed. Understanding the multifaceted nature of schizophrenia is crucial for effective management and support. According to the DSM-5, five core symptoms are used to diagnose schizophrenia: delusions, hallucinations, disorganized speech, abnormal motor behavior including catatonia, and negative symptoms. Delusions are fixed false beliefs, while hallucinations involve exaggerated perceptions, often auditory. Disorganized speech can manifest as loose associations, tangential responses, or even incomprehensible word salad. Negative symptoms include social withdrawal, poor hygiene, and diminished emotional expression. At least two symptoms must be present for a month, with one being delusions, hallucinations, or disorganized speech, and continuous disturbance for at least 6 months. Schizophrenia affects about 0.7% of the global population, with the most common onset in late adolescence or early adulthood. It is rare before adolescence or after age 40. The disorder is the ninth leading cause of disability worldwide. Lifetime prevalence ranges from 0.28% to 0.6%, but rises to 3% if a second-degree relative is affected, and up to 10% with a first-degree relative. If both parents have schizophrenia, the risk for offspring can reach 40%. Importantly, prevalence is equal among males and females. The exact cause of schizophrenia remains unknown, but various abnormalities in brain structure and function have been observed. These changes are not consistent among all individuals with the disorder. Multiple pathophysiologic abnormalities, including neurodevelopmental factors, may contribute. The neurodevelopmental model suggests that disruptions in cell shape, symmetry, and connectivity during brain development, possibly due to factors like maternal infection or stress, can lead to abnormal brain circuits and ultimately schizophrenia. Neurodevelopmental model proposes that schizophrenia may result from early brain development disruptions. Abnormal cell migration during the second trimester of pregnancy, possibly triggered by maternal upper respiratory tract infections, stress, low birth weight, neonatal hypoxia, or obstetric complications, can lead to lasting changes in brain structure. Imaging studies show decreased cortical thickness and increased ventricular size in affected individuals. Genetic factors such as those controlling NMDA receptor activity and autoimmune encephalitis may also play a role. Persistent decreases in gray matter have been found in several brain regions of individuals with schizophrenia, including the frontal lobes, cingulate gyri, and medial temporal areas. There is also an increase in ventricular size and a decrease in white matter in the corpus callosum. These changes reflect a reduction in axonal and dendritic communication between neurons, possibly due to abnormal neuronal pruning. Such alterations can impact cognition, emotion, and behavior, contributing to the clinical presentation of schizophrenia. Schizophrenia involves complex changes in dopamine activity within the brain. Increased glucose metabolism in the caudate nucleus is linked to dopaminergic hyperactivity, while decreased blood flow and glucose metabolism in the frontal and left temporal lobes suggest dopaminergic hypofunction. These imbalances can lead to increased presynaptic dopamine synthesis and release in the striatum, affecting D2-3 receptor availability. Such changes are central to both the positive and negative symptoms of schizophrenia. Increased densities of D1 and D2 dopamine receptors in the caudate nucleus and prefrontal cortex are associated with lack of motivation and cognitive dysfunction in schizophrenia. Positive symptoms, such as hallucinations and delusions, are linked to dopamine receptor hyperactivity in the mesolimbic pathway. In contrast, negative symptoms and cognitive impairment are tied to dopamine receptor hypofunction in the mesocortical pathway. Understanding these pathways helps explain both the symptoms and the effects of antipsychotic medications. Schizophrenia progresses through several phases. The prodrome phase involves glutamatergic synaptic dysfunction, leading to a glutamate signaling defect. In the prodromal phase, partial compensation occurs through GABA downregulation and synaptic proliferation. The syndrome phase is marked by GABA deficits, reduced inhibition of excitatory circuits, dopaminergic dysfunction, and the onset of psychosis. Finally, the chronic phase involves further loss of gray matter, compounding synaptic deficits and leading to persistent symptoms. First psychotic episode in schizophrenia often has a sudden onset, with few premorbid symptoms. Individuals may appear withdrawn, suspicious, or display peculiar behavior, sometimes described as schizoid. During acute psychotic episodes, patients lose touch with reality, experiencing hallucinations, delusions, and disorganized thinking. Affect may be flat, inappropriate, or labile, and behaviors can include uncooperativeness, hostility, or even aggression. Recognizing these features is crucial for timely intervention. After an acute psychotic episode remits, individuals with schizophrenia may continue to experience residual symptoms. These can include difficulty managing anxiety, persistent suspiciousness, challenges living independently, social withdrawal, poor hygiene, disturbed sleep and appetite, and even substance abuse. These residual features can significantly impact quality of life and require ongoing support and management to help patients maintain stability and function. Schizophrenia is marked by intermittent acute psychotic episodes and impaired psychosocial functioning between episodes. Most acute episodes occur within 5 years of the first psychotic event. Over time, especially in late life, patients may experience fewer acute episodes but continue to have persistent residual symptoms. This burnout phase can be challenging, as ongoing symptoms may still interfere with daily living and relationships. Visual representations can help us better understand the clinical presentation of schizophrenia. These images illustrate the progression from acute psychotic episodes to the residual phase, highlighting the changes in behavior, affect, and social functioning that patients may experience. Such visuals are valuable for both clinicians and caregivers in recognizing the different stages and tailoring support accordingly. Schizophrenia presents in several subtypes. The disorganized type is marked by significant disruptions in speech and behavior, flat or inappropriate affect, and fragmented hallucinations and delusions. This form tends to develop early, is chronic, and lacks periods of remission. The catatonic type is characterized by unusual motor responses and is considered severe but rare. Recognizing these subtypes aids in tailoring treatment approaches. Other subtypes of schizophrenia include the undifferentiated type, where major symptoms are present but criteria for other types are not met, and the residual type, where individuals have had at least one episode but now display less extreme residual symptoms. The paranoid type is also recognized, often involving prominent delusions and auditory hallucinations. Understanding these distinctions helps in diagnosis and management. Several disorders share features with schizophrenia. Schizophreniform disorder presents with similar symptoms but lasts only a few months and often resolves. Schizoaffective disorder combines symptoms of schizophrenia and mood disorders, with each occurring independently. Brief psychotic disorder involves positive symptoms lasting less than a month, usually triggered by extreme stress. Shared psychotic disorder and schizotypal personality disorder are also part of this spectrum, each with unique features. For a diagnosis of schizophrenia, the DSM-5 requires 2 or more core symptoms, with at least one being hallucinations, delusions, or disorganized speech, present for at least 1 month. Additional symptoms may include gross disorganization and diminished emotional expression. These criteria help clinicians distinguish schizophrenia from other psychiatric disorders and guide appropriate treatment planning. General goals of therapy for schizophrenia are to reduce the symptoms of the illness, improve patient functionality and quality of life, avoid unwanted side effects, enhance medication adherence, and prevent relapse. Achieving these goals requires a comprehensive approach that combines pharmacologic and non-pharmacologic strategies tailored to each patient's needs. In addition to medication, psychotherapeutic approaches play a vital role in managing schizophrenia. These may include cognitive behavioral therapy, social skills training, family therapy, and supported employment or education. Such interventions help patients develop coping strategies, improve social functioning, and enhance overall quality of life. Integrating these approaches with pharmacotherapy leads to better outcomes. Brain contains 4 key dopamine pathways relevant to schizophrenia. The nigrostriatal pathway controls movement, the mesolimbic pathway involved in behaviors, delusions, and hallucinations, the mesocortical pathway mediates positive and negative symptoms, and the tuberoinfundibular pathway controls prolactin secretion. Understanding these pathways helps explain both the therapeutic effects and side effects of antipsychotic medication. Pharmacologic therapy for schizophrenia includes first-generation antipsychotics FGAs and second-generation antipsychotics SGAs. SGAs are less likely to cause extrapyramidal symptoms EPS, have enhanced efficacy for negative symptoms and cognition, and are less likely to cause tardive dyskinesia. However, they may increase the risk of metabolic side effects such as weight gain, hyperlipidemia, and diabetes. Only clozapine among SGAs affects serum prolactin. Side effects are a major factor in distinguishing among antipsychotic medications. SGAs generally have a lower risk of neurologic side effects, particularly those affecting movement, but a higher risk of metabolic side effects. These include weight gain, increased cholesterol, and diabetes. Understanding these differences is crucial for selecting the most appropriate medication for each patient. First episode patients, medications like aripiprazole, olanzapine, quetiapine, risperidone, and ziprasidone have demonstrated efficacy. Lurasidone is effective in adolescents. Olanzapine is generally not recommended for first episodes due to its risk of weight gain and metabolic side effects. Quetiapine may result in less time to rehospitalization, but is also associated with greater weight gain. Dosing should start low due to increased sensitivity to side effects in first episode patients. Treatment progresses through several stages. Stage 1A involves starting with an SGA or FGA with careful monitoring. Long-acting injectable antipsychotics LAIAs can be considered at any stage as a patient choice. Clozapine is reserved for stage 3 after poor response to 2 different antipsychotics. Combination therapy is controversial and generally reserved for stage 4, where evidence for efficacy is limited. Certain factors predict a good response to antipsychotic therapy, including acute onset of symptoms, short duration of illness, presence of acute stressors, later age of onset, family history of effective illness, good premorbid adjustment, and effective symptoms. Conversely, negative symptoms and neuropsychological deficits related to cognition are associated with a poorer response to treatment. During the first 7 days of treating an acute psychotic episode, the main goals are to decrease agitation, hostility, combativeness, anxiety, tension, and aggression while normalizing sleep and eating patterns. First episode, patients are more sensitive to side effects, so dosing should be about half that used in chronically ill individuals. Monitoring for medication adherence and side effects is essential. Ensuring medication adherence is a key challenge in treating schizophrenia. Patients may attempt to avoid taking medication by cheeking pills. Using liquid formulations or orally disintegrating tablets can help. If there is no improvement after 2 weeks at a therapeutic dose or only partial improvement after 8-12 weeks, it's time to consider the next stage of treatment. Larger doses are not always supported by evidence. Calm a severely agitated patient. Intramuscular injections of aripiprazole, olanzapine, ziprasidone, or haloperidol may be used. Dosages are carefully selected based on the patient's needs and prior exposure to antipsychotics. If the patient is already on an antipsychotic, lorazepam may be added, but should not be combined with clozapine or olanzapine due to risks of hypotension and respiratory depression. Stabilization therapy aims for symptom improvement over 6 to 12 weeks. In the first 2 to 3 weeks, increased socialization, better self-care, and mood improvement are expected. By 6 to 8 weeks, improvement in thought disorder should be evident. Dose titration is typically done every 1 to 2 weeks. It's important to remember that antipsychotic medications are palliative, not curative. Goal of maintenance treatment is to prevent relapse. Medication should be continued for at least 18 months after remission, with some experts recommending up to 5 years and lifelong treatment for chronically ill patients. Tapering should be slow to prevent withdrawal symptoms such as insomnia, nightmares, headaches, gastrointestinal symptoms, restlessness, increased salivation, and sweating. Long-acting injectable antipsychotics, LAIs, are effective in reducing hospitalizations and preventing relapse. The decision to use LAIs should be made collaboratively with the patient. Transitioning from oral to injectable forms involves a short trial period to ensure tolerability. LAIs offer the advantage of consistent medication delivery, which can be especially helpful for patients with adherence challenges. Spiridin microspheres can require oral overlap for 3 weeks, with a starting dose of 25 mg and a range of 25-50 mg IM every 2 weeks. Dose adjustments should not be made more often than every 4 weeks. The extended-release injectable suspension (PRCRIS) is dosed at 90 or 120 mg monthly, with no oral overlap needed, and is administered subcutaneously in the abdomen. Olanzapine palmate monohydrate is administered every 2 or 4 weeks and does not require oral overlap. It is recommended for deep gluteal injection, with initial doses ranging from 210 to 405 mg. A rare but serious side effect is post-injection delirium sedation syndrome (PDSS), which occurs in less than 2% of patients, usually within the first 3 injections. Patients should be observed for at least 3 hours after injection. Fluphenazine decanoate is typically administered at 1.25 times the oral daily dose for stabilized patients, given weekly for the first 4 to 6 weeks. For more acutely ill patients, 1.6 times the oral dose is used weekly for the first 4 weeks. Afterward, dosing shifts to every 2 to 3 weeks. Oral fluphenazine can be overlapped for 1 week, with the dose halved at the first injection to reduce the risk of extraparietal symptoms. Haloperidol decanoate dosing is based on the oral daily dose, with the first dose being 10 to 20 times the oral amount. A loading dose of 20 times the oral dose may be used for patients at high risk of relapse or those tolerant to oral haloperidol. For naive patients, the initial injection is limited to 100 mg, with the remainder given 3 to 7 days later. Oral overlap is needed if a loading dose is not used. For maintenance, haloperidol decanoate is given at 10 to 15 times the oral dose once monthly. This approach helps maintain stable drug levels and reduces the risk of relapse. Careful monitoring during the transition from oral to injectable forms is essential to ensure efficacy and minimize side effects. Comprehensive monitoring plan is essential to assess both the effectiveness and safety of antipsychotic medications. This includes regular evaluation of symptom improvement, side effects, metabolic parameters such as weight, glucose and lipids, and adherence. Early identification of adverse effects allows for timely intervention and adjustment of therapy. Educating patients and their families about schizophrenia, its treatment, and the importance of medication adherence is vital for long-term success. Providing clear information about potential side effects, the need for regular monitoring, and strategies for managing symptoms empowers patients to take an active role in their care. Preventing relapse is a primary goal in the management of schizophrenia. This involves ongoing medication, regular follow-up appointments, and support from healthcare providers, family, and community resources. Early intervention at the first sign of symptom recurrence can help maintain stability and prevent hospitalization. Improving the quality of life for individuals with schizophrenia goes beyond symptom control. It includes supporting social integration, vocational rehabilitation, and access to educational opportunities. Encouraging participation in meaningful activities and fostering supportive relationships are key components of holistic care. Research into the pharmacotherapy of schizophrenia continues to evolve. New medications and treatment strategies are being developed to improve efficacy, reduce side effects, and address the unmet needs of patients. Advances in genetics, neuroimaging, and personalized medicine hold promise for more targeted and effective therapies in the future. To summarize, effective pharmacotherapy of schizophrenia requires a thorough understanding of the disorder's pathophysiology, careful selection and monitoring of antipsychotic medications, and integration of psychosocial interventions. Patient-centered care, ongoing education, and support are essential for achieving the best possible outcomes. A wide range of resources is available to support patients with schizophrenia and their families. These include mental health organizations, community support groups, and online educational materials. Connecting with these resources can provide valuable information, emotional support, and practical assistance throughout the treatment journey. Thank you for joining us on this in-depth exploration of the pharmacotherapy of schizophrenia. By understanding the disorder, its treatment options, and the importance of comprehensive care, we can make a meaningful difference in the lives of those affected. Stay informed, stay compassionate, and continue to advocate for the best possible care for your patients.